is this quality improvement? You know? And then let's get some basic tenets of CQI. We're going to go into the, how many of you know what that PDSA model is? So you're nauseous, right? Well, I'm going to go over it, but I want to do it the Sue way. So I have all the fancy slides, but we're going to talk about what it's like realistically. And I'm going to ask the people who do CQI to talk about how they've incorporated into the culture. And then we do the basic steps. They're very simple. They're not hard. And then this afternoon we'll do some examples. So I'm bringing you a bunch of different definitions of quality. Because when you think of quality, what do you mean by quality? We all know what it means to have quality food, right? It tastes good. It looks good. Hopefully it's sanitary. We know what that is. We know what think of some other things that we think about quality. We know what quality clothes are. We all have an image of what's a quality hotel. I don't know about you, but for me a quality hotel means a clean bathroom, a clean remote, and a clean, nice sheets. I'm really starting to say quality hotels have good pillows too. Right? But when you think about healthcare, what the heck does quality, there are 15,000 different. But if we're thinking about continuous quality improvement, what does it mean? One definition is the Institute of Medicine is the degree to which health services for individuals and populations increase the likelihood that you're going to get the outcomes that you want. So you're consistent with knowledge. But then I'm like, what about Disney? You know, Disney thinks about quality, right? It's attention to detail. It's all about the customer. How often when we think about quality do we think about the customer? We think about their outcomes, but do we think about their expectations? You know, it's again, what are the standards? And now, this is HRSA, HIV/AIDS Bureau. How many of you work in HIV/AIDS? How many of you know HRSA? Where are we meeting or exceeding the standard practices, professional standards, evidence-based programs, but also users' expectations? So we're beginning to focus. Now, Institute of Medicine. Are you seeing some things here? Likelihood of desired outcomes, professional knowledge. So one of the things that I think about because of what I do is I like the idea that the Institute of Medicine begins to talk about what are the key components. You know, we saw there patient expectations. We saw outcomes, using the best evidence-based practices. But that's kind of woo-woo, isn't it? You know, we've got to figure it out. I like this because it's safe. Care is safe. It's effective, which is the idea of outcomes. Patient-centered means we're dealing with the patient, not what we want. Timely, that we're doing things when we're supposed to do them. Efficient, and efficient doesn't mean like we work efficiently, but the use of resources. We're using the minimal resources to maximize the outcomes, and it's equitable. Now this is how I always used to justify all the efficiency work I do, because it's part of quality. You have to be efficient and effective to provide quality care. Capiche? Now, then there's this man called Don Abedian, and I can't remember his first name. When I started in healthcare 40, almost 40 years ago. No, I went to the Georgia Institute of Technology where I studied industrial engineering for healthcare. And we learned about, I think it's Avis Don Abedian. And he began to think about it as taking from other areas and apply it to other science, very focused on science and technology. And when I started, we talked about structure. When you think about quality, you think about structure, like characteristics of the agency. So somebody give me some ideas of what they think structure could be. You got it now. I got to raise your hand. I am not doing this alone. Okay, this is about being interactive. Hi, guys watching on video. Yes, I'm crazy. All right, who wants to say something? Okay, this is not going to work. Oh, good. She's close. I can get you out. Which mic do I give her? Go ahead.
Organizational chart.
The way the organization is designed, the org chart. Love it. Perfect. What else? Okay, I'll repeat.
Logic model.
What do you mean by logic model is a structure? Or does the logic model describe the structure?
Describes the structure.
Okay. But it's okay because you may want to think of that it also, the logic model. Logic model, does everybody know what a logic model is? Right? Inputs, outputs, outcome. It describes this. It's a tool we use. That must be an evaluation person. Are you an evaluation person or an epi person? Yeah. Those data people, they think like that. It's good we have one of those in my hand. Oh my God, you're really making me work this morning.
I don't know if this, but infrastructure?
Just give me an example of infrastructure.
HIV/AIDS division.
Staff.
Right.
Staff. How about medical records? How about we review everybody's credentials? Structure. We have a health center. We have a medical record. So you think about structure. It's how you've designed it. You may have an EHR. Do you have that yet? Well, you have that other, what's the data system? Falcon. I see, it's too close. So you have a system, right? Then you have process, what you do to the patients. What's process? Well, give me, that's the same thing as a process. Give me what that means.
The orders that we as nurses in the clinic follow for patients.
Thank you. So the process, so for example, if I come in and I have I'm going to do a lot of family planning examples, just bear with me. How many of you work with family planning and reproductive health? Okay. So there's a protocol if I come in and I've had unprotected sex and think something's going on, right? Well, and so you have processes, you have policies and procedures. Now the structure is that you have the policies and the procedures. The process is really what's in them. Does that make sense?
It could also be a planned intervention.
A planned intervention, like you have evidence-based practices. Give me an example.
Blood pressure monitoring.
Right, so the process is everyone gets a blood pressure. And you can track that and make sure that you're doing it. So if it's quality and you're saying 100% of the patients who come in have their blood pressure checked, that's part of quality. All right, come on, coming up. One up here, come on.
The follow-up to ensure the patient has...
Follow-up. So you have a set of 5 or 6 follow-up. So if I come in and I'm under 21 and I'm getting oral contraceptive for the first time, the follow-up is to come back in 3 months. If I'm 32, I won't come back. And if you still do that, please don't tell me because I don't want to hear. Right? And you see your processes change over time. Consistent with what? Evidence-based. What are the best practice standards? So when you think about quality, you think about it as how you set up the joint, what you do in the joint, and the outcome is what comes out. Now, how many of you have heard all about outcomes and, we look at outcomes. What are outcomes? What? The end result. But give me a specific.
Your client doesn't get pregnant.
Thank you. That's right. Your client doesn't get pregnant. What are some other outcomes? All right, come on, evaluation person. Diabetes. You keep them under their H1, whatever that is. Asthma. They don't go to the emergency room. You see, I only know pieces of medical. Is that all you need? That's all you need. So Donna, when I started in my first hospital in Clarksburg, West Virginia, our quality program focused mainly on structures, a little bit on process, but a lot on structures. We used to do a lot of I can't say chart audits, chart reviews, to make sure we had, that was the structure. and make sure the processes we're having, right? Do you all remember that? And then as time goes on, we now focus on outcomes, rehospitalization, right? Infections, how somebody does afterwards. So the shift, well, Donna Bedian's thing has been around for 50, 60 years. We see that quality has progressed in a way. And we really weren't data-driven back in the beginning. You know, we didn't collect a lot of data, right? We didn't collect a lot of data. We just reviewed charts. And we had a lot of, you know, a lot of the structure was getting people privileges, reviewing doctors' credentials. That was a lot of what we did with quality. Or we did an audit to figure out where we were. So when I came into the world, it was, we talked about quality assurance, right? Everybody knows that. And quality assurance is the planned and systematic activities so that you fulfilled what you're supposed to do. And if you remember, when you did quality assurance, you used to do just quarterly reviews, right? And you would say, okay, if you weren't, you know, if you did it up to 75%, we didn't do anything to you. If you were in that bottom half, we did a lot. Everybody remember those? How many of you remember those days? Okay, come on. I need a little bit of support here. And it was mainly done in hospitals. We didn't do any quality. I worked in community health centers in 1985. Let me tell you what I worked on. Strategic planning, right? Clean. A lot of quality on cleanliness, right? Right? We did a lot of checks. Remember, we checked to make sure we didn't have infections anywhere. We made sure we had certain things in way. That was all structure and process. What are you laughing at? You can't laugh and not tell me. That's one of the ground rules. You were laughing and I'm coming to embarrass you. Did you give them a heads up that I do that? So yes, that is something that's a new outcome that we're dealing with. Okay? If I see anything about erectile dysfunction on TV, I want to know, are they going to start advertising IUDs and oral and implants now too? Okay? What I'm trying to say is, though, even in family planning, the process has changed. Used to be that, you know, we wanted you to get any kind of contraceptives. Now we're under the quality family planning, it's about long-acting, reliable. So the focus has changed, right? So our quality processes are going to change. Here we go. Now we went to quality improvement. And quality improvement is that you don't just do it once. You constantly look at incremental changes. So I like to think of it, and I have a picture here on the slides, which you probably saw. But if you think about it, if you do something and the results are like this, we only did work in quality assurance over here, right? Remember that? But now what we're trying to do in quality improvement is move it over. So the first thing about improvement is it's efforts to seek incremental. So rather than you doing the same thing over time, to constantly move the dot. Everybody okay? But we took a long time to think about this incremental movement. So when I first started about 20 years ago, 15 years ago, in HIV, we were just thinking about that. And also when you think about it, it's much, if you're doing something incrementally, you need much more data, right? Because when you think about it, 30 years ago in my hospital, I did not have the access to the data I do today. I will share a story about, this is a quality improvement, quality assurance, because they were getting, one of the things that this hospital was very focused on was waiting time in admissions. That was one of the process, you know, the patient expectation, which we did. And we had a CEO very focused on it. And they were building a new wing. and they wanted to know whether they could centralize inpatient, ambulatory, and ER into one central process, central registration area. And I said, so I did this analysis where I looked at what was the distribution of when did people come to arrive for hospital admissions, when did they come for outpatient, and when was the ER. And I will tell you, I sat there and with paper, pens, I didn't have a computer. This is 1981. Maybe it was 81, 82. And I literally went, I had ticking marks. And I went through 3 months of stacks to see what time they came in and were admitted. Because we could do, you know, what time, and I looked at them and then I did a graph on an Apple where I had to go learn basic. But originally I did the graphs on graph paper. And I said, here's what you have. Your inpatient admissions are primarily in the afternoon, and your inpatients are in the afternoon, and your outpatients are in the morning. ER, there are no flakes, and plus they have nighttime. The CEO, I remember him looking at me, he said, how many hours did that take you? And I said, I couldn't tell you. I was having so much fun sitting in my office making ticking marks. Then they wanted to know, how did you do this? The CFO looked at me and went, oh, because I was a data-driven person. Today that would be really easy. What I did would have been nothing because the computer could have given you, you do a report that spits out the data. Well, what they also realized is part of the reason that there was the delay in the afternoon and why it took so, because I also looked at from the time they were admitted to the time they got to the room, because if I'm going through ticking marks and I have it, I'm going to maximize whatever data I had. And I said to them, I said, the wait time after 4 o'clock is horrific. Well, they didn't have enough. What do you think? Why do you think after like 3 or 4 o'clock there was a huge, yeah, because what they also realized is then when I saw that, I went, oh my God, let me look at when discharges are. So we looked at discharges, and we realized discharges, the overlap between discharge, look, this is 1981 and I remember this. The discharges, there was an overlap, and our nursing and our housekeeping staff was heavy in the morning. So we shifted the staffs. I came back and I redid the analysis right before I left to go to graduate school because they told me if I was that brilliant I shouldn't stick around and just do what I'm doing now. I'm just kidding. But it was the most fascinating thing. But that was quality improvement. Quality improvement was I analyzed it, I figured something out, and then I analyzed it again. Now, I don't know what they did afterwards. Once I left, I'm not sure they did a whole lot. But that's what we started to do, was we tried to move everything. So now what happened is, after a while, we began to go on, we did QI. But as we were able to get more and more data, it's a balance between making the improvements, which is quality improvement, and performance management, which means how are we doing? How are we performing? Now, so you have performance measurement, which is to figure out how you're doing. Well, until about, 12, 10, 15 years ago, there wasn't a lot of data you could tell to how you were doing, right? I'm a big, still believer in ticking marks, aren't we? Anybody who's ever worked with me, I've made them do ticking marks. So the development of continuous quality improvement is developing the systems, the ongoing process to support your QI. If it's continuous, you need to be able to have the what do you need in quality improvement? What's the big word that I haven't really said yet? What's the key? If you listen, chart audits. What did that do? Give us what? Data. What did I do with my ticking marks? So in this world, we need data to identify what improvements are necessary. So that's the whole idea of performance measurement. It's the idea of data. So, when you begin this CQI process, it's to develop ongoing everything's ongoing. What does that mean? You're collecting data. You've identified measures, and we'll talk more about it, but I want you to know, it's like the shift is, we used to look at data quarterly at quality assurance improvements. And what we would do is we would just look at it, and then we would do some things. And everybody, it went from just the bad things, people on the bad, not making the measure, to everybody's going to do something. And we design an intervention so that everybody participates. And think about it. When you did it, it may be you're tracking wait time in the health center, right? And it used to be we would only work really hard on the ones that had the bad wait time. But now everybody's going to work on wait time. And the other thing is the focus has gone from, I think it's become very much an evidence-based practice focus, right? And everything, there's research and there's working. I guess what I'm saying is, when we go to a CQI, it's really about looking at your organization, making data-driven decisions. And when you start, the thing that happens in organizations when I start doing CQI is people have experiences, right? And oh God, we have such a long wait time in the office. Well, that's an experience. You don't know what the actual wait time is. So the first thing to me when you start to think about continuous quality improvement, and this is nothing in PDSA, this is the Sioux version, is you begin to track data on certain measures, right, on an ongoing basis, whether it's daily, weekly, or monthly. And hopefully by looking at that data, you will be able to determine what I call the Bubblemainses. I don't know how do I say, nobody's Jewish in here. The anecdotal to data responses. So for example, how many of you heard about the 3-hour patient? And that's all we hear about, how long the patient spent hours in the health center. And that, people are complaining about wait time. To when you collect cycle time data on a regular basis. On average, it will take you 77 minutes to be here. Now, that can range anywhere between 35 and 92, depending on what type of visit you have. Approximately, so you're able to talk about what that is. My favorite one is no-shows. How many of you have no-shows? All right. How many of you, when you started to look at the no-show rates, who was that? So when I went to DeKalb, I'm coming up there because I want to talk to her. We tracked, because of work that I did in Anniston, I looked over time in their data on no-shows by hour of the day and day of the week. Does that sound familiar? Thank you to Anniston because they helped me design a tool that I still use, and we used it at a lot of things because you want to look at it. So what they do is now they look at it regularly, right? They track no-shows by time of day so that they can figure out how to double book with finesse so that they book extra appointments at the times that our no-shows are heavy. But they don't just do it and then not track any of the data. Does everybody understand that? They keep tracking it because this month it may be 10 o'clock and 12 and 2 o'clock. But that may change over time. So it's always looking at the data on an ongoing basis, whether that's monthly, identifying a trend, and then going from there. I love this table. I love this table. Why? So does everybody, because this really tells you my favorite things. So when I think, when I love this, catch the bad apples. That's going back. You want to get the ones who aren't doing it, rather than moving everybody. I talked a little bit about quality assurance, minimal standards, ongoing, organizational wide. A lot of quality improvement was done, quality assurance we did in structures, the surgical department and the emergency room. Now the whole hospital works on and have goals. And again, focusing on continuous, ongoing outcome. The QA approach is You see, they say actions when you got it. That's just what I said, right? The baddies. Here you're going to get everybody to move. And that's why I love it. And I think about it, it's about everyone getting better. Public health departments have really gotten, and public focus on quality improvement. Primarily because everybody wants to be nacho accredited, right? Also, public health, there's an investment. You have to be able to have outcomes. I think about, I was here, as I was getting ready for this, I really went back and looked at the focus of when we started, because I really didn't start doing CQI. I really started doing presentations, Monroeville. Was anybody in my Huntsville? Nobody's here from Tuscaloosa. We really did just about clinic operations and improvement. I always have a data-driven approach, but we then began to realize that you have to do it from a data-driven approach, and that's why I did Aniston, and we started thinking about CQI back in, that was 2009 and 10. But then we did the whole program, which I think was 2011 or 12, where we began to really have you explore this whole notion of continuous quality improvement. And that was mainly focused on your operations. The outcomes were not like what percentage of your population got LARC, or how many people had not the population-based work now. But now you're even looking at that. So what are some, so there's a lot of focus on outcomes because there's a public investment, and the public health departments want to be able to document what has occurred out of that investment. So it may be, started out with a lot of about infectious diseases. And, TB, public health departments did TB a lot. So immunizations, what are the outcomes? We're trying to prevent diseases and public health needs. I like definitions because is because it's the deliberate and defined improvement process. They use Plan, Do, Check, Act, whatever you want to use. It's a process, it's a deliberate looking at your data, identifying, and we'll talk more about that, which is focused that are responsive to community needs and improving population's health. Outcomes. You're looking at, let's go back to that Donna Bedian, right? You're looking at your structures and your processes. How are you looking at them now? With data. The man was brilliant. That's why we still call him. Data. And then how do you result in the outcome? Now we're just, you think about it. 50 years ago, we didn't have access to the data we do today. And it's about a continuous, ongoing process. Now here you see what we saw in the Institute of Medicine. Efficiency, effectiveness, performance, accountability. We want to look at creating services that achieve equity and improve the health of the community. The truth is, why are we doing all of this? What's the point of all of this continuous quality improvement? If not to improve the health of the community. That's your outcome. When you think about a public health department, a lot of them these days don't, other than in the South or other places, don't have public health centers anymore. They don't do direct service anymore, right? But here, you want to have an impact on the health of the community. And there are certain things that you look at because they impact the health of the community. For example, infectious diseases. That's why and immunizations. It affects the health. So the goal of this is to how do you continuously improve the health of the community.
I did want to reinforce something you said about the data before and after, because sometimes we have these great ideas and we think we're going to just change something, but unless you measure it before and after, the idea may be a fabulous idea, but you really don't know if it works if you don't have the data.
So what I hear from my friend Valerie, and I'm going to stay right here, okay, so you can all twist your necks. it's not about just getting the data after or before, that you have to have the data before and after to assess whether what you thought was a great idea really was, and did it address the issue. How do you measure performance, right? How do you measure performance? So I'm trying to break this down into pieces. So when you think about it, what is performance? I love this. Performance is you take some behaviors or actions and you have results. I love that idea. Like when I saw that, I went, oh, that's so perfect. Because you know what? You think about it. If you're an exerciser and I'm not, right? You have a performance. Or if you're a dancer, you hear of a performance. Well, it's a behavior and a result. Think in your own lives where we measure performance. We may measure our, certain behaviors with how we're saving money. We have certain behaviors, like we stopped going to Starbucks. What a shame. Now I don't love Starbucks. We stopped Dunkin' Donuts. And the result is we take that money and we put it in a cup so we can tell. If you only focus on behaviors, you don't know if you get the results, right? And if you only focus on results, are they doing the right behavior? So you have to, when you do performance, and we think about it when you do performance evaluations. When you do them, you look at both their behavior and what's happening. Again, outcomes and behavior. Process, structure, outcomes, right? Behaviors are either in process or structure, and you always have outcomes. Do you see how it all comes to, is my point of that it all comes together? It's not very complicated. And we make it so complicated. What is performance management? It's basically you're collecting data. You're looking at something. Are you achieving the outcome that you want to achieve? What's your goal? And are you achieving? So if I think of it personally, I want to save $500. The goal is, so I'm going to have behaviors. I have certain actions. I'm not going to Dunkin' Donuts. I'm taking all my dollar bills at the end of every day and putting them in an envelope and not touching them. I'm not going to go out with the girls except one night a month. So all those things that I would do, I would be able to say, okay, this has been this. So I've made some actions, right? Then the performance is not just taking those actions, but then collecting. So if I don't go to do coffee every day, I put $2 away. If I used to go out with the girls 4 times a month and it cost me $20, 3 weeks I put those $20 in a separate. I have to have the actions related to the change in behavior. And then at the end of the month, I see how much I have towards the 500. Do you want me to go? Is that clear for everyone? Thank you, I did not use the weight loss story. Now, if you're doing continuous performance management, you're going to count that envelope all the time, because if it's the middle of the month and you only have $20 and your goal is 500, you may have to change the actions. Like you could not give up your Dunkin' Donuts. Or my other favorite one is, I'm going to bring lunch every day. How many of you have that when you're saving money? Yeah, and you know how many days you do that. But then one day somebody said to me, well, you know what? I say I'm going to bring lunch every day, and I put the $10 in an envelope. And then every day I don't bring lunch, I have to still put $10 in the envelope. So I had to, do you know what I mean? So my favorite is putting the dollars and the $5 bills away in an envelope. And I've done that, and I have saved money. It's just really hard when you get that $100. I did it once. And you know what? It's amazing. I also did the throw the change. That doesn't work as well because I need quarters for laundry in my apartment or parking cars. But those are little changes. So when I think of CQI and performance management, the first step is, what's the goal? So how many of you have heard of performance management, that word too? the key to all of these structures that people are making lots of money on is to ensure goals are consistently met. It's a framework. It's a framework that we use. So this is Turning Point Performance Management, and there's 4 quadrants into designing a PMS. So when you do CQI, it's inside of a whole performance management program. So the standards, so there are standards that are out there, right? 10% of the cases of pertussis under children. So, or there's other standards. 100% get a sexual health standard. So as a public health organization, you've created standards. Do you know those standards? So one of the things is if you're beginning to do CQI, you need to know what are the standards. Okay? Because they all feed in. You can't do CQI unless you have standards. Does that... Again, I know, and each organization develops their standards individually. And then you measure. So you have a standard. 90% of all women, 85% of all women getting contraceptions will have LARC. Then you have to develop a measurement of how you're going to collect the data. Now you may have, and what you do is you're going to have different measures. So for example, you guys are organized in areas. So there'll be a national, but then each of you will have different specific measures. You may, what region are you in? 9. 9 may not have the same measure as 2. They may not have the same standard because it's a different population. You're at 22%, he's at 54. The first year, getting to 95 is not going to work for you. But more importantly, measurement is about collecting the data. If you're going to have a standard, you've got to have a way to collect it. And you all have to collect it consistently the same way. So I could have just had this slide called data, data, data. And that you all collect it and you define it. See, you have standards so that you can define what the measurements are. Because once you see what the measurements are, the standards are, you know what to measure. Got that? Standards, then you have to figure out what to measure. Here's the thing. You want the measures to tell you if it's working or not. I put these slides up basically because I wanted it to be real. I don't read slides, as you can tell, and I'm trying to read. So the measure has you allow you to tell if what you're doing is working. You collect the data to tell you if it's working. And if it's working, you should be achieving your goal. If you're not achieving your goal, then something's not working and you have to go back and investigate. That's basically what this whole thing is all about. The whole CQI, collect data. Are you achieving a goal? If you're not achieving the goal, what's working and what's not working? What's the change? That's basically this whole thing, right? Really, people are making a lot of money on something that's really very simple. But it's not simple because it's about what? What's the big word I've used? Yes, where's David Bowie when we need him, right? It's about change. It's about the thinking. But, right?
I have to apologize because I'm retired and I'm not actively involved in what the organization is doing right now. But I am involved in quality from the perspective of inpatient care in hospitals. And I do realize what the industry is doing now in the way of not only having data, you said something earlier, DDD, triple D.
Yeah.
Data drives decision making.
Correct.
And I'm not sure that that's happening. A concern that I have is most of the people that we have in this room are people that are doing the work. Are they being involved in setting the standards?
Well, let me ask this. I don't disagree with you.
Okay.
When we did the work in Anniston, and when I did the work in DeKalb, we met with the whole staff.
Okay.
When I did the work in Tuscaloosa, we met with the whole staff. I'm a big believer you got to do that. And you have to use the data.
Right.
Now, I will share with you that I worked with, and I'm going to use this. The thing for me is, it's about getting buy-in. So when you a lot of organizations, when they design the measures, they're based on what the government wants or nacho, but you don't get the buy-in from the staff. And I think that when you do the work, we shared, I don't think I did it in Anniston where I literally shared with them, but I was there and I was talking. And let me tell you, I was honest with them. When I walked in at 3 o'clock in the afternoon and there was no patients around and everybody was picking, dusting, reading, whatever they were doing, doing administrative work. I was like, hey guys, you can't do this anymore, right? So it's about sharing the data. First of all, you want to share the good and the bad. We always focus on the bad, but we don't do enough celebrate, right? So I worked with an agency, and I'll be honest, it was a WIC program. And I did cycle time. I also did appointment tracking. And we worked a year. And the goal was to achieve a certain level of participants, that's patients, in WIC work, a day for each of their nutritionists. And we looked at how to, looked at no-show rate, looked at scheduling behaviors, all the activities. And I will tell you more about what happened. But we had the staff. I worked with the leaders. I then trained them to speak every step with the staff at all their health centers. And they did, and they talked a lot about how great it was. Well, then we had a big old staff meeting, and then they had these individual, they had these little where people could say whatever they wanted. And it was sort of anonymous because you're not with your other staff. And they had 27 clinics that I was working with. And we got feedback about what was working and what wasn't working. So to your point, my friend, if we had to check in with the staff, I couldn't just leave it with what the supervisors were telling, but the senior management knew enough that they had these anonymous surveys that we could then check in with what's happening. A lot of healthcare is afraid of that. In my opinion, I think hospitals are afraid of it. They come up and you hear, my favorite thing is, they're making us do 15-minute appointments. They're making us do this and that, and there's no buy-in. So when when we do the quality, it's about getting buy-in. I would say, share the data, and it's about sharing the data. I will tell you, I once made people do hand graphs of data, and the woman who funds it, oh my God, no wonder it's so busy this day. Our capacity and our demand, we have a more demand than capacity, just like this much. And they made one change, and the next time she came back, she was all about data-driven decision-making. So when I think of reporting is, you can't just collect the data, you got to report it out, right? And the last piece of it, to me, is quality improvement. We're going to talk all about that in the next 2 hours. Well, I've always done it. But I wanted to do a fun example. So when you think about it, I talk about, let's manage the performance of a marathon runner. He trains 5 times a week. He records his times, and he seeks to do better than he did last year. So what's the performance measure? His time. His time from last year, he has to do better, right? That's the performance, that's the goal. Then he has to track his time, right, as he trains. So he's training 5 times a week, tracking his previous time. He's measuring when he tracks every time. He keeps a log, and his improvement is his strategy. But what he did was each week he would look at what he did versus maybe what's some improvements he could do. Stretch more. Do longer splits to make it easier so you're more comfortable with. So rather than doing 5-mile splits, he's going to do 7 miles because that helps him build up his energy.